Okay, we're set.
All right, good morning, everyone. Happy Friday. Thank you all so much for inviting me to present some of the work that I've been doing this past year. I'm sure everyone can agree it's been quite the wild ride. So my name's Rafael Gonzalez. I'm the Community Programs Manager at a Clinical Trials Unit within the San Francisco Department of Public Health. Originally, we work on HIV prevention research, but as soon as this pandemic began, given just our organization's expertise in conducting clinical trials for HIV vaccine research, we were pretty much set up with the infrastructure both locally and internationally to participate in conducting COVID-19 clinical trials. So aside from the clinical trials, I've been working on a couple of projects independently with other groups. So I'm going to share with you like a hodgepodge of things that may be of interest. I literally just 5 minutes before I hopped on the call was still adding slides. I just couldn't decide on what I wanted to share with you all. So I'm going to go ahead and start sharing my screen. And we'll go from there. Can everyone see that okay? Great, excellent. All right, so just a little about who we are. Like I said, the organization that I work for is called Bridge HIV. We're a clinical trials unit within the San Francisco Department of Public Health. This is just a little picture of our staff. And for reference sake, Bridge HIV, our organization, is tucked in the Population Health Division of the San Francisco Department of Public Health. We also collaborate a lot with UCSF and the San Francisco General Hospital. Now, when I was saying that not only are we set up locally to conduct COVID-19 vaccine clinical trials, we are part of a global network called the COVID-19 Prevention Network. It's based out of Fred Hutch in Seattle. And as of early August, we are one of 189 sites working on harmonious protocols. All these little dots that you see throughout North and South America, Central America, and certain countries in Africa, we are all working on the exact same studies. Of course, there's other clinical trials happening outside of this network. Asia, Europe, they're of course working on other COVID-19 vaccine studies, but these dots here represent a network of sites that are all working on the same research studies, trying to answer the same questions, collecting data in the same ways. So it's definitely quite a collaborative effort. These are kind of like general slides here, but I think I'm preaching to the choir at this point, right? We know what SARS-CoV-2 is. We know where the coronavirus and COVID-19 gets its name from. It was discovered in late 2019, hence COVID-19. We know that this virus affects the respiratory tract. We are still learning other ways that it can affect or impact the human body, but we know it's a respiratory tract virus. And we also know that symptoms can manifest in different ways. Some people could have mild to severe illness, sometimes resulting in needing to be treated in a hospital setting. And other folks are totally asymptomatic and may not even know that they're carrying the virus. We also have a pretty good idea now of how this is spread through aerosolized droplets that can occur from breathing, coughing, sneezing. And some of the main common symptoms can be a fever of over 100 degrees, cough, difficulty breathing. Again, we also know that there's some other obscure symptoms like loss of olfaction and sense of taste, and others. But these are kind of the main three. And these symptoms can manifest anywhere between 2 to 14 days after being around someone who has COVID-19. Again, things you've already heard over and over and over again. Reducing the spread can be done by practicing excellent hygiene, cleaning frequently touched surfaces, avoiding large gatherings, particularly indoors, maintaining physical distancing of 6 feet, and of course, wearing a face mask. Now, in terms of what's going on somewhat locally, in California, we have 2.8 million cases. This is as of January 13th. So as of Wednesday, we have had 2.8 million cases and 31,000 deaths due to COVID-19. In terms of race and ethnicity, this is kind of the breakdown, and one of the numbers that's been concerning and very steady is that both in California and in San Francisco, people who are Hispanic or Latino account for over half of COVID-19 cases as well as deaths. So this is quite concerning, and I'll explain a little a project that's happening here in San Francisco to try to address that. But in San Francisco, we have about 27,000 reported cases of COVID-19 since last March, and we've had 241 deaths here in San Francisco. Now, the information that I wanted to share. So in San Francisco, like I mentioned, the majority of COVID cases and deaths are happening in the Latino community, specifically in the Mission District. The Mission District, specifically the zip code 94110, is the most dense census tract in San Francisco. Very, very populated, lots of multi-generational homes, lots of folks living in one space. And so this is a reason why we're seeing lots of COVID cases coming out of the Mission District. And so a coalition has formed. There's about 30 some odd organizations that serve Latino communities. And in collaboration with UCSF, this coalition called Unidos en Salud, or United in Health, they have been working continuously for the last year on advancing access and effectiveness to COVID-19 test and response. And so they've been doing these community pop-up testing sites. The first one was last April, and it took place in 4 different sites in the Mission, one of them being at Garfield Park, some of them being led out through middle schools. And this has been a way to provide low barrier COVID-19 testing. And so we're currently working on a project right now in the Mission. It's a 3-week project. It's in collaboration also with with BART, our Bay Area Rapid Transit System. And so we're there 5 days a week, providing free COVID-19 testing. And what's been really amazing too is that we've been able to offer people who do test positive lots of support and assistance. For example, providing food, cleaning supplies, depending on what the living situation is. If some people test positive in a household and others don't, we've even been able to provide a quarantine hotel access. So it's been quite phenomenal work that this group has been doing. Now that was all kind of extra information that I wanted to add, but really what I wanted to talk to you about is the COVID-19 vaccine clinical trial we've been working on. The San Francisco Department of Public Health and SF General have been working on the AstraZeneca vaccine trial. This particular vaccine comes from Oxford University out of the UK. Today is actually an exciting day because we, by the end of the day, completely have enrolled this study. I'll tell you more about that, but our goal was to enroll 30,000 participants in this study. And in fact, we slightly exceeded that by 2,000. So we're at 32,000 participants enrolled in this study. And this is really exciting because that means that soon we'll be able to analyze this data, present it to the FDA, and hopefully get this authorized for emergency use. So a bit of technical information here, right? When we're talking about the SARS-CoV-2 virus, this is what we're talking about. What you're looking at here is what the coronavirus looks like under a light microscope. And you could see here that the virus sort of looks like there's a halo around it, or a crown. And this is where it gets its name from. Corona in Latin means crown. So this is the crowned virus. And that crown is made up of spike-like proteins. This is really important because these spike-like proteins are what cause the infection. So this is what we'll be focusing on, this spike-like protein. Now, in regards to understanding vaccines, I'm sure you all know. So right now, while we don't technically have an approved vaccine, we do have 2 authorized vaccines. The difference between an approved vaccine and an authorized vaccine, an approved vaccine gets approved once the entire study is completed, once the data is fully analyzed, and then presented to the FDA for licensure approval. Right now, we have emergency authorized vaccines, which is when we do the earlier data analysis. The reason why we wanted to enroll so many people is because there's powers in numbers. The more people we have enrolled in the study, the more obvious the data can be to make decisions. And so right now, the FDA has decided to authorize both the Pfizer vaccine and the Moderna vaccine. We do anticipate the AstraZeneca vaccine also becoming authorized for emergency use, as it's already been authorized in the UK, in Brazil. No, I'm sorry, not in Brazil. It's in the UK, it's in Mexico, and it's in India. So one of the most frequently asked questions is, can the vaccine cause infection? And the answer to that is no. The vaccine only contains synthetic copies of a piece of the virus that's made in a lab setting. The pieces are used to teach your body to recognize the virus without showing your body the virus itself. So for example here, when you see a wheel with spokes, a chain, or a pair of handlebars, you'll probably think of a bicycle. But you can't ride this bicycle with just those 3 parts. Or for example, if you take your mobile cell phone apart and you have a SIM card and just pieces of the cell phone, you wouldn't be able to send a text message or make a phone call. They wouldn't work because you only have parts. In the same way, when you only have pieces copied from the virus, there's no way that the pieces could come together to create the real virus. And so this is why we could say with confidence that the vaccines cannot give you an infection or cause COVID-19 illness. So here what I'm showing you on the left is what the coronavirus looks like. And on the right, we have a human body cell. And so on the virus, this is kind of zoomed up close what the spike protein looks like. And the spike protein wants to attach itself to a human ACE2 receptor. All of our human cells have tons of different receptors, and they interact with different proteins in the body. The coronavirus's spike protein specifically wants to attach itself to the ACE2 receptor.
By the way, now you can't get on any Sutter Health site.
Oh, so I think about this
we have
like I think about this like a key and a lock, where the spike protein is a key and the human cell receptor here is the lock. We want to avoid or prevent the key getting into the lock or the spike protein attaching itself to this receptor. This is what we want to avoid. This here is an image, again, of what we want to avoid. What you're looking at is the beginning of an infection. So the coronavirus's spike protein has successfully attached itself to the ACE2 human receptor. So how do we want to avoid that? By stimulating the body, the immune system, to produce protective antibodies. The antibodies are here in purple and green. Antibodies are sort of shaped like the letter Y, right? The letter Y. So the arms of the letter Y, this part here in purple, the arms of the letter Y, attach themselves to the spike protein, making it so that the spike protein cannot attach itself to the ACE2 receptor. In other words, what this is doing, it is neutralizing the virus by blocking every site in which it could possibly attach itself to a human cell. Then the body of the letter Y, right? So the arms are busy attaching itself to the spike protein. The body of the letter Y then signals your immune system, specifically your T cells, to come over and digest or metabolize the entire virus. So in this way, you don't have this neutralized virus just kind of floating through your body. It's digested. So before study vaccines are tested in people, they go through a long development process. Researchers have ideas for vaccine products, but only the best ideas move forward. First, these ideas get explored in a lab under a microscope and using other lab tools. And if an idea seems promising in the lab, it goes into studies in animals. It's really important to do this step in animals first to see how their bodies respond before moving ahead with testing in people. However, or of course, what happens in animals is not always the same as what will happen in people. Now, once human studies begin, there's very careful monitoring of study volunteers to keep track of any side effects or symptoms that they may have, and to make sure that they get any care or treatment that's needed. Once we have enough data from the preclinical or lab research studies, we move into the stages of a clinical trial. And this is when we're now working with people. So there's 3 phases. Phase 1 involves a small number of relatively healthy volunteers. And the question at the phase 1 level is the vaccine safe? Once we have enough data, we move into phase 2. This involves hundreds of volunteers. And the question at the phase 2 level is, what's the best dose of this vaccine? And what's the best vaccine administration schedule? Should it be given out every 3 weeks or every 3 months? Once we've determined that and we have enough data to move forward safely, the final phase, which is where we are at now in phase 3, this phase involves thousands of volunteers. And the fundamental question is, does it work? Can this vaccine reduce the severity of COVID-19 illness? And can it prevent illness altogether? So I'm sure you've all heard that all of this is being done faster than usual. What is really important to stress is that we're not skipping any of these steps. We're just changing the structure of how the work is done. So for example, doing some steps in parallel instead of one after the other. We're also overlapping some of the phases, starting the next phase just as soon as we have the safety data collected and analyzed from the previous phase. And then of course, there's several external groups that are overseeing everything that we're doing. The FDA, for example, the National Institute of Allergy and Infectious Diseases, the US Biomedical Advanced Research and Development Authority, or BARDA. So there's external bodies that are monitoring, first and foremost, the safety of all of our participants. So with regard to the vaccine, the idea behind vaccines is, again, to show your body a piece of the virus, because it doesn't need to see the whole virus in order to recognize it. In the same way that when you see a slice of turkey or ham or cheese, maybe peanut butter and jelly, you know that these can be components of a sandwich, even when you see them individually. So making a vaccine is kind of like making a sandwich. You need something to carry the vaccine from your plate to your mouth, which would be the bread, and then you need a filling, like meat or cheese. That would be the insert or the antigen. So the bread would be called the vector, right? What's on the outside. And then the meat, or what you fill your sandwich with, is called the insert, which contains an antigen. So viruses from other animals are commonly used as vectors, or the bread, for making vaccines. The human body quickly recognizes that there's something foreign, and it makes a strong immune response. In this case, it's the chimp adenovirus that's the vector, and it acts like the carrier, or like a delivery truck that has to deliver a package. The scientists that made the vaccine inactivated this chimp adenovirus so that it cannot cause infections or colds in people. The package that it carries is a copy of that spike protein that I showed you a photo of earlier. The vaccine then delivers that protein package, or the spike protein, to cells in the human body so that the immune response that the body makes will be specific to fighting off the virus. I won't spend a ton of time here, but this is a sort of comparison, if you will. This on the right is an explanation of the chimp adenovirus, which is what the AstraZeneca vaccine is using. And I'm showing you the mRNA type of vaccine, which is what the Pfizer and Moderna, the two vaccines that have been authorized for emergency use, they're using the mRNA strategy. AstraZeneca is using the chimp adenovirus strategy. Something really interesting to know is that this mRNA strategy, which again, Pfizer and Moderna have used, there's never been a vaccine that's successfully used this strategy. So this is kind of a major breakthrough that Pfizer and Moderna successfully created a vaccine using this strategy. Meanwhile, the chimp adenovirus, using this method has been done many times. In fact, sometimes it's used for the flu shot. And so for that reason, Another very interesting fact is because the AstraZeneca study using the chimp adenovirus, it's using a technology that we're very familiar with. It wasn't very new. It's much cheaper to produce this vaccine versus the mRNA vaccines because they had to, spend money on investigating something totally new, this mRNA technique. The chimp adenovirus is a tried and true technique. So the cost, I believe the AstraZeneca vaccine costs $3 to $4 to make, whereas the Pfizer vaccine costs $25 to make a dose. So again, the study's nearly full. Today's the last day, but so that you know who we were enrolling in this study. It was folks over the age of 18. This particular study has not yet focused on youth or people under the age of 18. And we were specifically trying to enroll people who may be at risk for infection. So this would include adults over the age of 65, people with underlying health conditions like heart disease, diabetes, asthma, people with a greater chance of exposure due to their work or living situations, folks who work in elderly care facilities. This particular study did not work in jails or prisons. Other studies did, this one did not. And then we also wanted to enroll people from racial and ethnic groups that have been impacted in greater numbers, such as African Americans, people who identify as Latino or Hispanic, and American Indians. So I already told you what the main questions are, right? So throughout the clinical trials, we've been asking, is it safe? Is the vaccine safe? Can the vaccine reduce the severity of COVID-19 illness? And can it prevent infection altogether? Now, this slide here is already kind of outdated because it says over 5,000 volunteers have received at least one dose. But this was based on the first 2 phases. You could add 32,000 people to this number now. We have over 37,000 people that have received at least one dose of the vaccine. And what we've seen is that the side effects of this vaccine are common of most vaccines. So soreness at the site of the injection, mild flu-like symptoms like fever or fatigue, but we have not seen any adverse reactions. And unlike the Pfizer and Moderna vaccine, which they've seen some anaphylaxis due to people that may be allergic to certain antibiotics, we have not seen that in the AstraZeneca vaccine. So the design of this study was a double-blind randomized study. And in fact, all of these clinical trials have used this design. It's kind of the golden standard of clinical trials. What this means is we have 2 groups where the first group or one group receives the actual vaccine product and the other group receives a placebo. In this case, the placebo is a sterile salt water solution. Neither the participants nor the researchers know what the participant is receiving. And this is so that the care that's offered to participants is totally unbiased. If I knew someone was not receiving the vaccine, I may give them additional care, right? And so in the end, when we're analyzing the data, there's some bias there that maybe I was giving more care to those that were not receiving the vaccine so that they would, reduce their risk even more. In the end, these 2 groups are really important because we're able to compare data to see, did the vaccine work? And so the randomization here was for every 2 people that received the vaccine, 1 person received the placebo. So in total, 20,000 people received the vaccine, 10,000 received the placebo. And this randomization process is random, right? Like flipping a coin. Of course, we don't flip a coin when the participant comes. It's a computer software, but it's the same as flipping a coin or rolling dice. It's totally random. No one decides which group you're in. Now the study visits, there's 7 study visits when you're participating in this particular study, and it's over the course of 2 years. You'll notice that the first 6 visits here are all in the first year. And the last visit, the 7th visit, is at the end of your 2-year mark. So 2 years, but only 7 visits. Lots of phone calls in between though. We definitely want to check in on our participants and make sure that everything's going okay, that no unexpected reactions are occurring, etc. Now, at the first 2 visits is when the participants receive their injection at enrollment, and then 28 days later, they receive their injection. The rest are simply follow-up visits, which look like a general physical exam when you go into your doctor's office. And then just wanted to point out that, how did we do it? So here in San Francisco, our site alone was tasked to enroll 250 people in 2 months. It's been a wild ride. Our clinic's small. We have 8 clinical rooms and we have 5 clinicians here. So to have enrolled 250 people in 2 months, we've had to reimagine how our clinic works, what our flow is, not to mention, as you all know, lots of medical mistrust and lots of misinformation. So it's been really important to us to enroll a cohort that represents what our local epidemic looks like. And so we've been really adamant about enrolling people from diverse communities. And so we created this campaign, as well as our website, We Can Beat COVID. It's also in Spanish, Combatimos COVID. And we hope that what we've done here is a grassroots effort at mobilizing people. So for starters, we worked with an artist here who is from San Francisco, a Latina identified woman from the Mission District. And she created what she considered and called a culturally responsive campaign, creating images of real people that she knows, that she got consent from, and that, display representation. And our goal, depending on if we continue to work on more studies, is to work with more artists and take this kind of activism art approach, which we've used in the past for our HIV research studies. Now, this website has a questionnaire, a survey that one takes to basically know if you're pre-eligible for a study. And one thing that we've also needed to be really mindful of is what's called the digital divide, right? So even having this website is kind of biased. Not everyone has access to the internet or is tech savvy. And so if we solely rely on this website as our recruitment strategy, we're gonna get one kind of person. People, not one kind of person, but people that have access to this technology, which then could lead into, their socioeconomic status, social behavioral status, things like that. So what we've done is we've printed out posters and flyers of all of this with information on the back side. And we've focused on some of the zip codes and neighborhoods with the highest levels of COVID-19 infections. And we've done some major canvassing, going door to door, spreading awareness, postering at businesses wherever we're allowed, letting folks know in person of this, the importance in participating in research, and providing an alternative way to be screened. So rather than coming into this website, there's a phone number that you can call or text message. And we're also, when we're doing canvassing, we have tablets so that we, if you don't have access to any, a cell phone or a mobile device with internet, we can screen you right there and right there. And then I have a few slides left. I will point out this is not my area of expertise. We've been focusing on doing the research for vaccines. I've also personally been working with the group that I mentioned earlier, Unidos en Salud, on low barrier testing. I am not involved in the distribution of COVID-19 vaccines. However, what we do know is that the anticipated plan is as follows. So in November and December, we got FDA approval for emergency use authorization of the Pfizer and Moderna vaccine. Then starting in December, the approved vaccines started to go out to different priority groups, starting with healthcare workers. And now that we're in mid-January, that is being extended to frontline workers, people over 65, and people with pre-existing conditions. Starting next month in February through April, vaccine distribution to the 4 priority groups will continue, with roughly 30 million vaccines distributed every month. This is nationally, right? Vaccines become more widely available to youth and healthy members of the general public around April. And then in July through September, most adults who want the vaccine likely have had access at that point. So we're hoping that by August of this year, most people who want it have received it essentially, or at least been offered and have made an appointment to receive it. Now, something to note is that so far, the 2 authorized vaccines are 2 doses. So, for example, when we say 30 million doses here, we're really talking about 15 million people because we need to reserve that second dose for those people. And because of that, the vaccination process can take actually about 3 to 4 weeks per person. What we hope is that by the end of the year, around November, December, we reach herd immunity through the vaccination of about 75% of people. Now, regarding local distribution here, the data I had access to was through UCSF. So again, so far, the group that has been offered vaccines are healthcare workers. And what I'm showing you here is specifically healthcare workers at UCSF and SF General. There are about 23,000 people that are part of this group. And so far, almost 100% have been offered the vaccine. 82% of those that have been offered the vaccine are consenting to get the vaccine. That's great. There is a tiny discrepancy between those that have consented and those that have actually already received their first dose. 79% have received the first dose. And so they're looking into what's going on here? Why is there this discrepancy of people who have consented and people who have received it? It's possible that it could be a language issue, or again, that digital divide that I mentioned, where people may not actually know how to sign up and register. So they're looking into how to make that more accessible, and how to maybe like guide someone through the process a bit more intimately. So that's 79 of the people, 79 doses scheduled, of the first dose scheduled. And so far, 77% of our healthcare workers have received the first dose. Again, that's a great number. We really want at least 70% of healthcare workers to be willing to receive the vaccine. Just because, as you can imagine, healthcare workers, a nurse can tend to about 100 patients a day. And that could result in, that nurse being a super spreader. So we really, really want to make sure and aspire to getting at least 70% of our healthcare workers vaccinated. Again, it takes about 4 weeks to be scheduled for your second dose. So far, we have about 17% of folks who have already received the second dose. Finally, I know I've talked your ear off, so apologies. Again, this is not my area of expertise, but I did want to share some of this information regarding new variants of the virus. So we've had one predominant virus or version of the virus circulating, and this is like 99% of the virus globally. This is the original one. Since then, they've identified 2 different variants. You've probably heard in recent weeks that there's a new UK variant, and that now there's also a South African variant. The UK variant circulating is like there's different versions of this variant already. We know that it's more transmissible. However, there's no evidence that this new version or this new variant will not, that the vaccine will not work for it. There's no evidence. So we do believe that the vaccines that are being rolled out will be effective against this UK variant. Yeah, that's all I'll say about that. And we do know that this UK variant, it is in the United States. We've had about 72 cases. This is as of yesterday, so it may have changed, but we have 72 cases in the US of this UK variant. And that's of what we know, right? It is expected that there are more cases of this UK variant in the United States. Of those 72 cases in the United States, 32 of them have been found here in California. The other variant was first detected in South Africa. This South African variant has now also been found in 11 different countries. However, it has not been found in the United States yet. This one's particularly concerning because it is possible that the mutation that has occurred on this virus may impact how the vaccines that are being produced can affect this particular strain. So it's for that reason very, very important for our local government and our federal government to really get on this mass distribution effort. The sooner we get people vaccinated, the sooner or the less that we need to worry about these new variants. So with that, I say thank you, and we could have a conversation now. I did see that we had some, let's see. I'm looking in the chat. And I have, please explain how participants are selected for the COVID-19 clinical trials. Looks like
Do we know?
someone signed up and actually, unfortunately, didn't receive a call. So there are lots of factors in selecting someone who can be eligible for a trial. Some of it has to do with health conditions, medications that one takes. It's pretty extensive, so I won't go into all those details, but you know, if someone has an autoimmune disease, for example, they wouldn't be eligible for this study. If someone recently received the shingles vaccine or another vaccine, not the flu vaccine, but the shingles vaccine, that would make you ineligible for a period of time. And then a lot of it does also have to do with potential risk. You know, if someone is able to shelter in place or work from home and, you know, they're really not interacting with people outside of their household, then the reality is they're not at risk, and that's wonderful. But at the phase 3 level, we do want as a real world like setting as possible. So we want folks that are working in restaurant settings or in factories or in retail, people that are out and about, so that we know that if we say that this vaccine works, it works. Again, if we had a large group of people who were able to be at home, how would we know that the vaccine works if they're not interacting with people? We do, of course, do lab analysis. Blood is collected at the different visits, and in the lab, they're looking at levels of antibody production, etc. But we do also need to look at the social dynamics. And for that reason, you know, some people may not be eligible for the study. Let's see. Although, is it Johnson & Johnson that has developed a one-dose vaccine? That's correct, Sheila. So far, Johnson & Johnson is the only vaccine that is just one dose. They just finished enrolling in the last couple of weeks. And so right now they're doing the interim data analysis. We expect to hear what the results are in the next month, maybe 2, but I'd expect, you know, they're going quick. So we'll learn more. I'm due to get the second shingles shot this Monday. If I get it, how long do I have to wait to get the COVID shot? Great question. I believe, at least in the clinical trial setting, it was 1 month. Do you know if any of the vaccines have been tested with dialysis patients with advanced kidney disease? Bonnie, that's also a great question, and I don't know. I could look into that and get back to you all through Sarah, perhaps, but I'm gonna make a note of that question because I don't know. I know that our trial, this would be a reason why you would have been ineligible, right? Like,
Raya, you want to eat in your room?
eventually they will definitely invite people with other health conditions, but that's not where they started. But I'm definitely going to get some more information for you because that is a great question. Sorry, folks, let me just make sure I get the question written down correctly. Great. All right. I hear that you should wear a cloth mask, but most healthcare workers wear surgical masks, which are made of paper. So in fact, I don't know exactly what the material is, but the best option other than an N95 is actually going to be a surgical mask over a cloth mask. When you come into our clinic, if you come with your own, I mean, you'd obviously come with your own mask. But if you came with a cloth mask, we'd ask you to switch it out. I don't know the data on this either, unfortunately, but I know that this, outside of using an N95, is your best bet. Let's see. A few questions. Given push to vaccinate more people with one dose and stretch the time before giving the second dose, what's the impact on vaccine effectiveness of lengthening the time between the doses beyond the interval recommended by the trials? Also, what have we learned about treating people, particularly older adults who are infected? All right, Barbara. So to your first question about the interval between doses, it's really interesting. So with the AstraZeneca study, something bizarre happened. So we're giving 2 full doses in this study. And we're seeing that it's about a 60% effectiveness. Now in Brazil, participants were given half a dose first and a full dose 28 days later. And I should say 28 days later, because actually what happened is people came late, people came after their 28 days. So what we saw in Brazil, which by the way was only about 2,000 participants, that's not enough participants to make a generalized statement. But what we saw in Brazil is that in receiving half a dose first and a full dose later, it was actually more effective. We saw that it was about 90% effective using half a dose first, a full dose second, instead of 62% effectiveness in using two full doses. That's kind of counterintuitive, right? Because you'd think the more the merrier, the better. Now, it's kind of an enigma right now. There's not a clear solution, because what also happened, like I mentioned, is that people came later than their 28 days. Some people came as late as 12 weeks after their first injection. And so there's a hypothesis that it was actually not due to the half dose, full dose, rather the length of time in between. So that's something that they're looking into. What I can say, I doubt that any country is actually going to change the schedule of dosing, just because these clinical trials were designed in a very specific way. And so the recommendation, once they are approved or once they are authorized, is to follow the program, follow the way that the clinical trials were conducted. So while there's talk about it may be better to just get out, if we have 30 million doses, right? That would be for 15 million people because it's 2 doses. Some people are saying just vaccinate as many people with that first dose and then we'll figure it out later. There's some sense there, but it's not going to happen. I don't foresee that happening. It's kind of unethical to go off the rail with what's been done in clinical trials. But it's really interesting. I will say we're learning lots with, again, just the dosing regimen and the dose itself. Now, the second part of Barbara's question, unfortunately, I don't think I can answer because like in our HIV research, our trial or our organization focuses on prevention. Our colleagues at SF General focus on treatment. So we're kind of like the before, they're the after, pre and post, if you will. So I could also look into that. But right now, unfortunately, I don't want to contribute to misinformation. So I'm going to pass. But thank you for the question, Barbara. So let's see. Do we know the degree of efficacy on the AstraZeneca vaccine? If not, when will we know? So I think I may have already answered that question, but I'll say it again. So it's looking like the 2 full doses, which again is probably going to be what's administered, is about 62% effective for AstraZeneca. Now, obviously, this is different than the Pfizer and the Moderna vaccines, which are 95% as Pfizer, and then Moderna is 94.5% effective. And so this is 62% effective. So it is a difference. Right now, there hasn't been, when the healthcare workers who are getting vaccinated, we don't get a choice on whether we get the Moderna or Pfizer. It's just whatever they have in storage that day. It will be interesting once and if, but I'm assuming once, the AstraZeneca vaccine is authorized. It'll be interesting what the ethics will be in terms of what your option will be, right? Getting a 95% effective vaccine versus getting a 62% effective vaccine. It may be, and it's still in the works, right? It may be that folks over the age of 65, people with underlying health conditions, and like healthcare workers / essential workers and first responders may get access to the Pfizer and Moderna vaccine. And then young, relatively healthy people will be offered the AstraZeneca vaccine. That's a possibility, again, not clear. Also, something that I imagine with the different vaccines. Remember how I said that because AstraZeneca is using technology that has been used before, we're familiar with it, this chimp adenovirus. Because we're using it, it's cheaper to make, $3 versus $25 a pop for Pfizer. Because of that, I suspect that the AstraZeneca vaccine will actually be one of the vaccines that's distributed globally, particularly to third world countries. Another reason outside of the cost is storage. So Pfizer, for example, is a vaccine that needs to be kept super duper cold. It needs to be kept at -70 degrees Celsius. Not many places have a freezer that can reach such negative cold degrees. And it's because of this that Pfizer, I mean, think about when it's being transported from one place to the other. It would be really difficult to get this to, South American countries or countries in Africa, because there's a cap in terms of time, and then this temperature storage caveat. Meanwhile, the AstraZeneca vaccine can be kept in a refrigerator. It's more stable. The Pfizer vaccine, there's some instability, and therefore it needs to be kept very, very cold. So all really interesting considerations. I attended a virtual conference, of course, of local, well, like in the Bay Area, local municipal clinics, like free and public clinics. And it was kind of sad. Now, this was back in December, I want to say early December. And it was just really surprising that the storage of it was such a barrier. A lot of the municipal clinics said, we're not going to be able to participate in the distribution of this. We're not going to be able to get this to our communities and our populations because we don't have a freezer that's this cold. So again, there's lots of caveats to consider. I know that initially there was talks of Pfizer collaborating with like Walmart and CVS because they had the ability to have freezers that were that cold. I'm not totally sure where that stands. I also recently heard that all of our local sports teams have offered their fields and arenas for mass distribution sites. So the SF Giants, the 49ers, the Oakland A's, and the Sharks, they've all offered their venues as locations for mass distribution. Let's see here. I have food allergies. I heard that some allergies might bring on negative reaction with the vaccine. Should I be worried? So that's going to be kind of case by case, Clint. I would definitely recommend that you speak to your doctor. Depending on the severity of these food allergies, that could possibly be linked to this anaphylaxis issue with the Moderna and Pfizer vaccine. But again, just to note that this is specific to the Pfizer and Moderna vaccine because of the technology that they're using, right? They're mRNA vaccines. The Johnson & Johnson, I'm actually not remembering what strategy they're using, but it's not mRNA. We're using a chimp adenovirus. And then one of the next ones is using a protein as the vector. So it is possible that you may be recommended not to take the Pfizer or Moderna vaccine due to this allergy, but that's something that your doctor would have to assess. If you're immune suppressed, you need a different dose of COVID vaccine. That's a fantastic question, Lucy. I'm going to write this one down too, because I'm not 100% sure. I know that there's been certain autoimmune conditions that were excluded from this eligibility criteria, but I'm not sure what the recommendation is going to be for this one. Again, the data needs to be analyzed for the AstraZeneca vaccine, but I am definitely writing this down. You all are coming up with great questions. And again, I'm sorry that I don't have all the answers, but I just don't want to give the wrong answer. So I'm writing this one down. Again, though, I don't think that, at least at this moment, that we're going to move away from the dose that, you know, we studied. So I don't think right now that other countries will approve to go in a different dosing regimen. But again, I'm writing this down. Okay. Given the increased infectiousness of the new variants, I've read we should do more home delivery and less in-store shopping and wear at least a 3-layer mask. What do you think? I'm not sure about wearing a 3-layer mask. I don't know how much more effective it's gonna be. But I mean, in general, yeah, I would say like the more you can avoid densely populated places, do that. But it's also just so soon, you know, like there's still lots to be known. 72 cases of the UK variant is not a lot. I don't know what the numbers are like in the UK and in some other countries, but it's still kind of too soon. And within that variant, I think there's like 20 something mutations, you know? So there's lots of variability. And again, we need more numbers to be able to make generalizations. So right now it's still kind of unknown. If the South African variant gets around antibodies created by other vaccines, is there a reason to wait until the vaccines work against the South African virus? I was thinking about this too last night. Again, some of these things are my opinions, right? I think it's still worth getting the vaccine when you're offered it, because even though the South African variant, this may not address the South African variant, the original variant still makes up 99% of global infections. So that's still going around. And then there's this UK infection variant, which is more infectious. And we do think that the vaccine works against it. So I would say it's still a good idea to get vaccinated if you are offered it and you're comfortable with it. Do we know how long after the initial vaccinations we'll need a booster? And if so, does it have to be the same vaccine that we had before? Is there a PDF of this meeting you can send us? Awesome question. That second part is really, really interesting. So Alice, the first part of your question, the only one from what I've read, and there's so much to read, so I haven't read it all, but the only thing that I've read is regarding the Moderna vaccine. It looks like antibodies last about 1 year. I don't know. We don't know yet with the Pfizer. We definitely don't know yet with AstraZeneca. But if this is going to be the case, then this might look like, you know, the flu vaccine where we're getting this every year. Of course, you know, even though we have a couple of authorized vaccines and we have, you know, a couple more in the pipeline, we're going to be working on more vaccine studies. With more time, you know, we'll be able to, well, the lab scientists, I should say, will be able to come up and produce vaccines that are more stable, that don't need to be kept at such crazy temperatures, and hopefully ones that last longer. That's what I'm imagining is going to happen. What will be interesting is how the clinical trial designs will need to change, right? If you remember, these studies so far have been a double-blind randomized study where we're comparing a vaccine to a placebo. Now that we're having authorized vaccines, it'll be pretty unethical to continue doing vaccine studies where we're requiring people to receive a placebo when we have approved vaccines, you know? So that's yet another caveat of how we'll need to figure out how to design future studies so that we could, you know, find even more effective vaccines. So to answer your question in short, the only one we know is Moderna, and it's looking like it lasts about a year.
Hello?
Hey there.
Yeah, I actually saw Dr. Fauci on CNN one night,
Mm-hmm.
and somebody asked him the question, do you need to get the same vaccine? And he said yes.
Yeah. Oh, I'm sorry. So I didn't answer that part of the question. Thank you, Gloria.
Okay.
Yeah.
All right.
So yes. Now, in regards to, you know, your first dose and second dose, yes, you should get the same vaccination, right? You shouldn't get like one dose Pfizer, another dose Moderna. I don't, however, know, for example, if these products will be lasting a year. In a year, I don't know if the answer is you should stick to the same vaccine, right? So are you receiving the Pfizer one up front and then in a year you need to get revaccinated? Can you get Moderna? That I don't know.
Okay, the question I have is I'm 76 years old and I have three pre-existing conditions. So am I going to be stuck getting the AstraZeneca because I'm older?
No, in fact, I think that you'd be offered probably very soon, like in the next few weeks, you'll probably be offered either the Pfizer or the Moderna vaccine. Yeah. Let me see, because there was that second question that I thought was fabulous. Oh, okay. I actually already answered that.
Yeah, is there a PDF of this meeting you can send us?
I'm not sure what you mean by a PDF. So Sarah mentioned that this is being recorded, so I think that they could send out the recording. I don't have a PDF though.
They may have meant the PowerPoint, but yes, you're right about the recording.
Yeah, the recording will have all the slides.
Great, thank you.
Sure. All right. So if you get one of the current vaccines and months later a more effective vaccine or one that protects you for a longer period is approved, can you get that newer vaccine? We don't know. So for example, what the information I can offer. So someone's enrolled in our trial, the AstraZeneca trial, right? They're blinded. So they don't know if they're getting the placebo or the vaccine. Let's say in a couple weeks, that participant is offered by their healthcare provider the Pfizer, the Moderna vaccine, right? At that point, we would ask that that person, that participant, let us know that their provider has offered them one of the authorized vaccines. We will then unblind you. Normally, we unblind participants at the end of the study. So 2 years later, we'll unblind you. But right now, what we're doing is case by case. So if we unblind you because you're being offered one of the authorized vaccines, we unblind you and it turns out you're getting the placebo. We encourage that participant, go for it. Get the vaccine that you're being offered. Now, if you've been receiving the AstraZeneca vaccine because you were in the vaccine arm or group, we'd say, you got the vaccine, you should stick with the vaccine that you got. Of course, at the end of the day, it is your prerogative. It's that participant's prerogative to decide, that's great, I got the AstraZeneca vaccine, I still want that Pfizer vaccine. The recommendation at that point is talk to your doctor, make your decision. However, there is no research looking at what happens when you receive 2 different vaccines. So it sucks. Sometimes I can't give straight answers, but it's because things are still up in the air. So maybe in a couple months, we could meet again and I could have some updates for you then. Can the efficacy of the current trial increase at any stage above 62%? It's possible. It is possible. I don't know if the plans are to conduct other trials that are using other dosing regimens. Right now, we are sticking to the 62%. But it's possible that in the future we might try, that half dose, full dose, or maybe more time in between. But right now it's 62%. Where do I go to get the vaccine? Linda asks, and that's another awesome question. They're figuring things out. So I do know that, hospitals will be vaccinating. I know that Kaiser will be doing it. UCSF will be doing it. SF General will be doing it. I would assume that, like Sutter Health will be doing it as well. But there's a lot of people out there that aren't currently linked to healthcare. And so we're going to probably see these kind of pop-ups, like I mentioned, like the Giant Stadium has offered to be a mass distribution site. I don't know what that'll look like, if they'll do it in the parking lot or actually in the stadium, but that could be an example. The group that I mentioned, United in Health or Unidos en Salud, this group where we've been doing low barrier testing, it's likely that we will become a vaccine distribution site in community settings. So far, most of our testing efforts are outdoors. Like we're literally over on the corner of 24th and Mission by the BART station. I don't know if we'll be able to, administer vaccines on that same corner. So it's likely that we'll move to slightly different locations, maybe again out of a school or in an open park field, like Garfield Park is quite large. So that would be a good idea. Um,
Rafael, this is
Yes.
Jessica from San
Hey.
Francisco Village regarding this question. We've had members ask if they've reached out to their primary care physician who wasn't sure how to answer this question, where they can get the vaccine. I'm a patient of UCSF, and I've received an email saying they will inform us when it's our time. So just to, should we wait, I'll wait until the primary care physician's office reach out to us, to those who are connected to a hospital and a clinic, or should we reach out to them at this point?
So I would imagine that they are gearing up a system. I know that I believe the system is called My Chart. I don't know if that's what they're going to use for everyone, but the system currently has been one called My Chart, and they are sending out emails. For those of you who may not have an email address or check your email often, I would definitely let your provider know that you should be contacted in a different way, whether that be a phone call. But while it was just this week, I believe, that Gavin Newsom made the announcement that, we're officially starting with 65 and up. The announcement was made, but the logistics aren't quite there yet. But this is all moving really, really fast. I'll tell you, I got my first vaccine the week of Christmas, and I was super surprised that it happened that quickly. And there was no notice in advance. It was like from one day to the next. So it is a very fast process. So it's hard for me to say, because again, distribution's not my thing really, but I imagine that people will start getting contacted in the next 2 weeks. And if you don't, then I totally, so you got to be your own advocate sometimes. If you don't hear in the next 2 weeks, it's totally worth making a phone call. Let's see. I heard you say in the trial, you were choosing at-risk people, including those with underlying disease. Could you talk a bit more about that in relation to, for example, kidney disease or other immune disorders? Also, do you know how currently dealing with the lack of refrigeration in the community clinics? And did you say you are expediting the AstraZeneca beyond the trial groups? So again, I did write this down, Jessica, because I don't know about kidney disease and dialysis patients, for example. So I'm gonna follow up and get more information on that. To your second question, well, so the question is about how are sites dealing with this refrigeration issue. Right now, only centers or clinics that have the appropriate refrigeration are the ones receiving it. So for example, these municipal clinics that I mentioned are not receiving Pfizer yet. I should point out that Pfizer's the only one that needs to be kept at such low temperatures. Moderna is kept at -20 degrees Celsius, where Pfizer is -70. And AstraZeneca is just kept at regular refrigeration levels. And then the last part of this is, did you say you are expediting the AstraZeneca beyond the trial groups? We're not expediting. Can you maybe explain more what you mean so that I answer the right question?
Yeah, I thought maybe I missed it when you said it, but how close what is going to take for AstraZeneca to be distributed?
Oh, got it. So yeah, so because today's the last day, starting probably this weekend, there's going to be a massive data clean, get everything set up so that the data can be analyzed and then eventually presented to the FDA. I would expect that in the next I can't imagine that this will take more than 2 months. I'm hopeful that it'll take like about 1 month, that we'll have the data figured out, sorted, analyzed, ready to present to the FDA. And then that turnaround process is about a week. So I would hope, that I would hope that the AstraZeneca vaccine will get approved like late February to mid-March. At that point, also, I should point out that for the people in the trial, right, if they haven't been offered the vaccine through their provider yet, and then AstraZeneca becomes authorized for emergency use, everyone in the study will be unblinded. And everyone who received the placebo will be offered the AstraZeneca vaccine through the trial. Hopefully that answered your question-ish.
Rafael, do you mind if we take a couple minutes for people who might not be able to type a question into the chat?
Absolutely.
So if you have a question and you aren't familiar with chat, if you want to raise your hand, I'm scrolling through these pictures.
Mhm.
Just knowing we all have different technology capacity.
Oh, and look, someone in the chat, Alice, said that she's scheduled to get her first dose of Moderna. Her doctor called her to let her know. So that's awesome. So I'm thank you for sharing that, because I've been curious to know whether this was exclusively going to be an email situation, which I think is problematic, but that's great to know that they're also making phone calls and that it's starting.
All right. It doesn't look like I see any hands raised, so we can go back to the chat for the questions. Thank you, everyone.
Okay, let's see. I want to make sure that. So Clint, you're asking, are there ways that volunteers could help? Could you elaborate?
Well, I don't have I don't have a specific idea, but I just, is this all self-contained, or is there ways that, civilians can go ahead and help with the process of getting this out to the public, or?
Oh, I see. So I don't think that and I'm not sure if you're referring to like the study volunteers, the people in the trials.
Just general population.
Got it. So I was, and I don't have the full list, but I was just reading either yesterday or the day before that they have expanded the list of those that can deliver the vaccination. So at first it was like doctors and nurses, but now there's, pharmacists have been included, dentists have been included. I thought that was kind of neat, but it makes total sense that a dentist would be allowed to administer a vaccination. So they are widening who can actually administer vaccines, which will ultimately, add to this supply chain and distribution administration.
Well, I don't feel qualified to administer, if you mean by administer, you mean inoculate somebody.
Yeah.
Oh, I can't do that, but
Neither can I.
right. So, I know you work with HIV, and I remember the horrible times back in the 80s when they're always asking for volunteers. And I know this is a very different situation, but I'm just wondering whether a layperson can somehow help in this process. And I have no specific idea of what that help would be like. That's why I'm asking you.
Yeah, I haven't heard any talks of that. It would be really interesting. I mean, it sounds necessary, but I don't know. I don't know if, just a lay person could be trained to administer a vaccine injection.
Or just drive somebody to a hospital or.
Well, I do know that like Uber and Lyft, for example, are promising like millions of free rides for folks who are not able to get to, the vaccine distribution sites.
Okay.
Yeah, they've promised like millions of rides. I don't know how that'll get coordinated, but
Well, okay. Well, then that seems like that's being taken care of. So.
yeah.
Okay.
Luckily,
It's just a thought.
thank you.
There apparently are the same number, or roughly the same number of people just doing administrative documenting as there are people who are administering the doses. And it might be that that's a possibility for volunteers to sit there and fill out whatever kind of form you have to fill out.
Absolutely,
And give
Bob.
you give you the document that you have that you need to come back and get the second shot.
Yeah, that's such a great point. Aside from actually administering the injection of the vaccine, there's all sorts of administrative processes, and that also requires lots of hands, lots of bodies. And so there are many people that are volunteering for, what they can. And I also believe that students, nursing students, medical students are being trained and allowed to be part of this process. Typically that wouldn't be the case, but there's lots of creative solutions that are being offered to have more hands on deck. Let's see. Where's the Johnson & Johnson vaccine? So that just finished enrolling in the last few weeks. They're probably analyzing the data. I will imagine that the Johnson & Johnson vaccine data will be presented to the FDA before AstraZeneca, just because it finished a little earlier. But the data is being analyzed for Johnson & Johnson. And absolutely, Sheila, we could totally use retired health providers. In fact, again, not my organization, but that group that I'm working with on doing testing, it's been really amazing, everyone, to see, it's really like the entire HIV workforce and research field has pivoted, So I've had the honor of working with some of the first nurses to work at, SF General out of Ward 86, which was one of the first wards. I think it was the first ward working with AIDS patients. Before then, before we understood what HIV and AIDS was all about. I had I'll share this. I know we're at time, but I'll just share this really exciting thing that happened, because I've been working in this field now for 8 years or so. And one of the retired nurses, lots of retired nurses and docs have come to be a part of this community mobilization and testing. And I was working with who they called Jane Doe. Maybe some of you had heard of her. She was a nurse working at SF General. She was the first nurse to get pricked by a needle that was contaminated by a patient with HIV and AIDS. And from there, she, took this to court, not to, get all this money or whatever, but she took it to court so that we can have more consideration for the occupational safety. I'm talking this happened when nurses and doctors weren't even using gloves and things weren't being sanitized. So for many years, she was anonymous. And it was actually just about 3 years ago that she revealed her identity. And it was just so moving and legendary, you know what I mean? To be working along some of these nurses that were the first workforce of, working with HIV and AIDS patients is just kind of like a full circle moment, because technically I'm now part of the first workforce working on COVID-19 with them. So it's been really, really remarkable. And I've had a lot of just wow moments. I know we're at time, so let me just see will we need proof that we've been vaccinated? There will be a document that you get that the provider will sign off on. I don't know if you'll need it for, travel in the future or access to certain things. I don't have information on that yet. But again, I want to respect everyone's time. We are at 12:02. I want to thank you all so much for listening to me ramble on, but hopefully y'all enjoyed it. And hopefully you can have me back. Again, everything's changing so quickly that I'm sure I'll be telling a totally different story in a couple months. So maybe we'll see each other soon.
Thank you so much, Rafael. I think we all really feel so glad to have you spent this hour and a half with you. I see lots of waves and smiles.
Thank you very much.
Thank you
It
all.
was excellent. It was excellent. Thank you so much.
Thank you.
Good.
Thank you.
Bye-bye. Be
Thank
safe.
you very much.
My
Bye.
pleasure.
so
Take
much.
care.
Stay
Stay
safe,
safe.
Rafael.
Thank you.
Thank
Thank you.
you.